Good afternoon, everyone. We're just going to wait a couple more seconds just until people get pulled through from the back end because it's sometimes a little bit slow. So we're going to start in about 30 seconds time. Perfect. I think we've got enough people through now, so I'm going to take down my my holding slide and get things going. So good afternoon, everyone, and thank you so much for joining us for this reform webinar on such an important topic, which is why health reform is so difficult. A few bits of housekeeping. We really want to make sure that this event is as kind of collaborative and participatory as possible. So I am going to leave a lot of time at the end for questions, but please do make sure you put your questions in the Q&A function because that's the bit that I'll be monitoring. So a little bit of scene setting to start. For decades now, we've obviously been talking about the kind of change that we need in our health system. So big changes like moving away from a kind of national health approach to from a national sickness approach to a true national health approach, moving away from kind of acute treatment focus towards much more early intervention and prevention, doing a lot more at a local level rather than a national level, thinking about the kind of join up of services between health and other public services. But despite successive waves of reform in all of those areas, some of which have even been labeled as so big you could see them from space, a lot of the kind of successful outcomes in those areas remain elusive. So with us today to discuss why that might be the case and what makes health reform so difficult, and hopefully to give us some thoughts on how we can get through that impasse, I've got three fantastic speakers. So first up is the Right Honourable Caroline Flint. So Caroline was an MP for Don Valley from 1997 to 2019, and amongst other ministerial roles, she was a Minister for Public Health between 2005 and 2007. And since leaving politics, she's been the chair of the Humber Teaching Foundation NHS Foundation Trust. Then secondly, we have the Right Honourable Sir Norman Lamb. Norman was a MP for a Lib Dem MP for North Norfolk from 2001 to 2019, and he served as a Minister for Care and Support between 2012 and 2015. And like Caroline, he's also the chair of an NHS trust. He's the chair of South London and Maudsley NHS Foundation Trust, which is a specialist mental health trust. And last but not least is Lord James Bethell. James has been a peer in the House of Lords since 2018, and during the pandemic, he served in the Department of Health and Social Care as a Minister for Innovation and Life Sciences. So to kick things off for this session, I'd like to pass to Caroline for some opening thoughts on what makes health reform so difficult.
Thanks very much, Sebastian. And the truth is, despite recurrent problems, delays, waiting times, and endless pressure, the public really do value the NHS. They have concerns, but they really value it. And in pretty much every opinion poll around, public policy, the NHS is usually at the top in terms of what the public feels so most protective of. And I think for that reason, any politician, or actually any policy group that seeks to, in their view, undermine its principles, I think faces resistance from the outset. It has saliency, the NHS, because people are treated every day, or they know someone who's treated, or they know someone who works in the NHS as well. And all in all, despite all the pressures that this webinar is part of a wider debate, it knows a good thing when it sees it. The truth is, we all know, and I won't repeat it, is that the inception of the NHS in the aftermath of a world war had the circumstances that was absolutely right for a major intervention on health. And whilst not all political parties supported it, it was overwhelmingly supported. But at the same time, as we know only too well, Nye Bevan and others could never have imagined what the demands on the health service would be today, not only in terms of the sort of conditions that would be in the top 3 of causes people's death today compared to what they were back in that period of the late 40s, 50s and 60s, but also the medical advances that meant that actually we could live longer with more support and intervention. And longevity is a massive issue that we are failing in, not just health policy, but in other policies to really think differently about. I think so that is a problem in itself, that although the challenges have changed, the model of delivery and public expectations have remained largely the same despite 75 years. I think the other problem is that reform is so often framed around calls for rationing and charging. Personally, I think this is a dead end. Politically, I don't think there's going to be any party who is going to develop a platform based on that. So I often think it's a bit of a non-runner and distraction. And Sajid Javid recently called for GP appointments to be charged, but I don't think there's going to be anyone who has real influence in public policy and legislation taking that one up. However, we know that we just simply can't continue down the path we're on. The NHS consumes a huge amount of the public budget. 1950, it was 3.5% of GDP. By 2020 and 2021, it reached almost 12% of GDP. That's some £277 billion. And again, this is the other problem, isn't it? And we're dealing with it today. A sense of crisis prevents long-term change. And so as to today's pressures will always consume, as they've always done, the time of NHS managers and politicians. And what will happen is short-term cash support will follow. Now, I was Public Health Minister. I was very proud of that. Under the last Labour government, we created the first Public Health Minister. And I actually believe, and because I was part of it, there was a renewed focus under that administration on tackling health inequalities, moving a shift to prevention, improving longevity, and not only that, the quality of life. That was all part of our discussions. But despite that, public health was always a poor relation. I was pitted, against my ministerial colleagues who all had hundreds of demands on them in terms of their asks. Whilst we did do some things to improve access to public health, they then later were affected by a lack of sustainability and building, for example, services in pharmacies, community health champions, bringing primary services together so people can have more treatment and more prevention help closer to where they lived. They were all there 16 years ago, but along the way, they've lost out when other pressures, particularly in the hospitals, have demanded more. And that has always been a problem. In fact, probably the most significant Labour public health outcome was ending smoking in enclosed public spaces in England. And that didn't involve the hospitals. It didn't involve the GPs. It was primarily non-health partners and, of course, the British public who made that work. And I'd like to think that I added my own contribution to that, staff at DH and others who really did a good job in delivering that legislation. We had targets on waiting times, and actually they were successful both for A&E and referrals, but it cost a shed load of money. And then, of course, it hasn't resolved the problem of demand. And we're back to where we were in some ways today in terms of those ever increasing waiting times, which were increasing before COVID. So we have to have a discussion that moves us just to reform just being about healthcare, one which I think reform are trying to encourage, which is about how do we create wealth? How do we look at this differently? Because if we don't do that, the NHS will just suffer a long-term decline. And importantly, the public of all ages won't be getting the health service they deserve, and the prevention services maintain their health as much as they possibly can. And that means we won't address capacity in social care or prioritise prevention. We won't address the reasons between the increasing numbers of children and adults waiting to be assessed or to receive treatment from mental health services. So without reimagining health, we won't tackle the real problems, not just for today, but for the next 50 years. And that's something we've got to get to a place where policymakers and opinion makers can find some consensus on.
Fantastic. Thanks so much for that, Caroline. And a huge amount to think about there in terms of things like how you bring the public with you on a reform journey, but also maybe how we reshape a lot of this conversation around health. So how we move away from a conversation that kind of fixates on this idea of healthcare and hospitals and moves towards really thinking about what creates health. I'm going to pass on to Norman now for his opening comments.
Many thanks, Sebastian. And I agreed with everything that Caroline had to say. I fear that might be a theme that runs through this discussion today. I think it's important for us, first of all, to be open and recognise that this is a very significant public policy failure. The fact that successive governments haven't really been able to shift the focus of our health system in the way that reform recognises is necessary, particularly with a greater focus on the health of populations rather than just the delivery of health services. And we should remember also that it sits along a complete failure of successive governments to reform our social care system. And the two are so inextricably linked. And if you don't reform and get social care working effectively, it will have a continuing, massively damaging impact on the NHS. I think at the heart of this, of the problem, is the sort of status of the NHS as a national religion. You know, and it's lauded through the opening ceremony of the Olympics, for example, and it results in politicians, and I've witnessed this so often, fearing being radical, fearing opening up a discussion in a rational way about where the NHS may not be delivering the results that we want to achieve. Just a very minor example of that, when I was minister, I took to our parliamentary party meeting a proposal to do a review of the role of social enterprise in the NHS. They've got a very good record, particularly in community mental health services, one of the best mental health services in the country, Navigo, run by a social enterprise. It was going to be chaired by Chris Ham from the King's Fund, a really good initiative. My parliamentary party were petrified that this would be framed as privatising the NHS, and they were resistant to me doing it. And it left me in a state of complete despair that Lib Dem MPs in government were so petrified of even looking at something as innocuous as the role of social enterprise. I think there's an additional point that the reforms that have been attempted too often have failed to deliver the results that we have hoped for. And the interesting thing is that since devolution, we've been able to look at different models, but according to the Health Foundation, actually all the different models haven't really fundamentally delivered different results. So we're stuck with the same problems as we've always had. I think counterintuitively, it's a bit easier for Labour governments to be radical and to think about levers such as choice and competition than it is for Conservative governments. And I welcome the reformist words of Wes Streeting. I think that's encouraging and should be very much welcomed by people across the political spectrum. Within the coalition, of course, we had the disaster of the Lansley reforms, and it had this extraordinary chilling effect that having gone through this sort of nightmare of public opposition and very strong political opposition to what was contained within those reforms, it just left the government unwilling to look at any more health legislation for fear of another disaster. So nothing really then could happen. I reached the conclusion, having been minister, that in a way, achieving a new settlement for the NHS and care was probably too big for any single party to do on its own. And we needed to be prepared to work across parties to achieve a sort of new Beveridge moment, a new settlement for the NHS and the care system. So I worked with Caroline and many others on trying to build a cross-party consensus. We called for what we called an NHS and care convention, which could have used, citizens' juries and this sort of thing to initiate a big public debate about the needs of the health system for the future. I talked to Peter Riddell, who was then at the Institute for Government, and he recognised that sometimes there are issues that are too big for party politics and need that willingness to work across boundaries. We met with Theresa May, but there was a fear that from the Treasury of losing control of a process, and so ultimately it just got absolutely nowhere. I will just mention Alan Milburn was interviewed on The Rest is Politics, I think last week. Really good interview. Alan Milburn is someone that I admired very much for being willing to tackle some of the sort of big, difficult issues within the health system and take on, in a way, his own party on that. And I see sort of some signs of that, as I mentioned earlier, in the approach that West Streeting is now taking, but not enough MPs also have been willing to take a serious interest in health policy. And I think that's another issue. And I don't see any real sense that the current incumbents in the Department of Health and Social Care have a real interest or understanding of how we get out of the mess we're in, a plan for how we recover from this existential crisis and reform the system in the way that is necessary. Thanks a lot.
Thank you so much, Norman. And again, a huge amount in there, including some kind of big machinery of government questions as well, which are how do we unlock long-term investment in the health system rather than thinking about kind of getting through the next crisis? How do we think about this being a cross-government effort, but also a cross-party effort? And those are all things I think we want to talk about more today. I'll pass over to James now for his opening comments.
Thanks, Sebastian. I'm going to try and build on what Norman and Caroline said. Both of them covered a huge amount of ground. So let me try and build on it by sort of taking a bit of a punt on being a bit more specific about what the challenge is. From my point of view, the biggest problem that we face is starts with a political problem, which creates an economic problem and is based around a social problem. The political problem is that there is no belief or confidence that Britain can be a healthier country. There is no momentum to make Britain the healthiest country in the world. Now, there is momentum to make us a science superpower, to be competitive in the city, to be a great trading nation. We are capable of self-identifying around some big missions. But when it comes to health, we are totally fatalistic. We are personally fatalistic about our own health, like people don't do much on the whole to try to make themselves healthier like they do in some other countries. Our clinicians, the whole manner of our health system is framed around a sickness service so that the modus operandi is that you turn up to your GP or to A&E coughing blood and then we'll fix you. That is the mentality, if I was to generalize. It's not true every detail, but that is the mindset. And from a government point of view, in terms of the politics of how we run things, the focus is therefore on waiting lists and building hospitals. That's where all the mind share goes. And that is what the political proposition from all the parties tends to be to the electorate. And that's why it's a political problem. The proposition is, we will reduce waiting lists, we will build new hospitals. I did nearly 100 hospitals in the last election to sell in 40 new hospitals, 50,000 more nurses, 6 million more GP appointments. In other words, an infrastructure build commitment, a workforce commitment, and a sort of consumer-facing commitment, all of which were framed around a sickness service, not around trying to make the health system better. That fatalism means that there is no political cover, no objective, no fundamental mission around which you can hang individual objectives. That then leads to an economic problem, which is that there's no belief that even if we did make the country better, that would deliver a return on investment. There's a skepticism, a lack of confidence that investment in health does deliver a financial dividend. And that is true of the Treasury across the board, whether you're trying to sell in a plane or an industrial strategy around rockets or whatever it is. The Treasury is nihilistic in its ambition, and it is skeptical of all ministerial policy. Sometimes they're right. I mean, quite a lot of the time they're right. But it takes you down this cul-de-sac where a big troubled sector like health simply can't back out of. And all we're doing currently is building more hospitals. It's very, very heartbreaking. And as a result of this, there's a social problem, which is we have no boundary between what is the state's responsibility and what is the personal responsibility. I am genuinely personally confused about what my role is in my own health. Is it up to the NHS to look after me? Is it social care and my education? Or what should I be doing personally? Should I be diagnosing myself? Should I be actively involved? Should I contribute financially since I have a job and can pay? It's really, really unclear. And if things are unclear, then of course it's politically toxic, as Norman said, to take a prod at that. And therefore, we can't make the decision socially about doubling down on health, because what we have about a quarter of the country has some kind of chronic disease at the moment. So we have a massive stock of about 15 million people who are carrying disease today. And we have a huge flow of people who are getting ill every year. And that is made worse by the bad air, the moldy homes, the junk food, the gambling, the stress. So we have a huge committed cost. A lot of those chronic people aren't going to get well overnight. And we need to spend money on reducing the flow. That's going to require, like any kind of strategic reboot, a period of double running. We're going to have to spend an extra 20 billion quid a year for 20 years, something like that. I mean, I'm just like picking numbers out of the air here, not quoting. But if you don't believe that the health of the country will actually get better, and if you don't believe that that investment will deliver, I know, 1 or 2 points of economic growth in 20 years' time, then you can't get your head around doing that. And so it's resolving that fundamental mission, that belief that Britain can get healthier. And I yearn for political leadership. So someone who can look down the barrel of the camera and say, I believe that this country can be one of the healthiest countries in the world if we pull together and do that. And if someone's prepared to take that political risk, the technology and the advances that we are seeing in vaccines, in diagnostics, in the application of big data and AI and quantum computing, they can be deployed to make a huge, huge difference. But it's all for nothing if that political belief isn't there.
Fantastic points, and I'm sure we all agree that we hope that political will is there at some stage. I can already see there's some great questions flooding into the Q&A function, so do keep those coming. I'll be very selfish and start with some questions of my own. The first one is about kind of prevention and how we do long-term thinking in health policy. I think everyone's noted the fact that one of the issues here is that the kind of return in investment in prevention, early intervention, tackling the social determinants of health is the future direction of travel. But the issue there is about kind of justifying why what might be upfront big investment will pay dividends in the long run, and how you kind of reconcile that with trying to resolve short-term pressures. So I was wondering if any of the panelists had thoughts on how we can kind of carve out that space for long-term thinking and long-term investment whilst we're trying to do the short-term crisis management. I might go to you first, Norman.
Well, it certainly requires a sort of will from government to facilitate that. But I also think that we need to recognise that the way in which the NHS is structured is not really facilitating change. I'm quite attracted by the Manchester approach. The fact, I mean, I happen to chair something called the Health Devolution Commission jointly with Andy Burnham, and the sort of central view of that commission is that we need to devolve much more power and responsibility, and we need to recognise that many of the things that result in the health of a community lie way outside the NHS. I mean, Caroline made the point about the biggest impact on health was the stopping smoking in public places, completely separate from the NHS. But there are so many services that local government runs that are fundamental to our health and our well-being. And we need to recognise that those social determinants of health and the pretty stark and gross health inequalities in our country really need to be confronted, I think, at a local or regional level. And I think only by bringing together the forces of local government and the NHS, bringing health and social care together more effectively, getting the right incentives in place, will we have any real success in developing this prevention agenda and developing a sort of sense that what we should be focusing on is the health of our communities. Totally agree with what James said. It's that people aren't ambitious enough to recognise that it is achievable to improve the health of our communities and to reduce the awful health inequalities that we suffer. But it requires a wholly different approach, and that can't be dictated from Whitehall.
I think we would also all agree on that in terms of the fact that this change can't be just driven by the central government. There are a few questions already coming in about that kind of balance between central and local, which I'm sure we'll pick up on. I might pass on to Caroline to talk about how you kind of try to do both that long-term strategic thinking and also the short-term crisis management, and maybe some reflections on what that feels like as someone who chairs a trust, how you carve out that space for doing things differently.
Caroline, I think you're on mute, I'm afraid.
Thank you, James. Sorry about that. I think one of the problems has been, and certainly when I was public health minister, around promoting and advocating for public health and prevention, is quite often the sort of the pathways, clinical pathways. It didn't fit into a nice, neat clinical pathway. And so it goes back a bit, it's a bit like with the Treasury thing, unless you could absolutely prove then and there that this intervention would make a difference, it was really hard to get traction on it against other demands. But we know actually, we know that health inequalities is unfair, but also it creates over a period of someone's life long-term impacts and costs on the NHS, and more importantly, that person's not enabled to be as fit as they possibly can be, even if they're living with a long-term condition. And to that end, I think that there has to be a way, and I agree with Norman, of recognising the different partners and the different ins into this debate. The truth is whilst local authorities have been given, the role of public health promoters, their budgets are just not significant enough, I think, to make a real impact in terms of procurement across the system. So they're behind before they've even started. I think also the data, I mean, obviously being a chair of a trust now, and I'm sure it's the same for other colleagues, is there's a huge discussion developing around health inequalities, but it's not like this is new. And there's part of me sort of thinks, no, that's really positive that we're having this live debate and questioning how we do it. But we had the data before. We know what are pretty much the determinants that are going to affect this area. What was stopping us doing it? And part of it, I think, is about the fact that all the partners aren't really interrogating the data and also what is provided to really beg the question, is this driving down on health inequalities in our patch? Is this actually making a difference? And actually, the truth is, in lots of cases, it isn't making the difference it should be. It isn't being targeted in the way it should be. But there seems to be an inertia, having discovered that, to have the flexibility to change things around. Now, look, none of us on this call, could have a situation where suddenly the health service stops doing everything it's doing, even though we might think it's misdirected to concentrate on another area. But we've got to create space in this to make that happen. And the ICSs that are in their early days, they have been charged with looking at population health, of using collaboration, not just within the health community but beyond, to really drive down on the numbers and do it differently. And that's what they're going to be judged on. And maybe they're within there's a space to make sure that they are held accountable for that, but also the wider system adapts in a different way to meeting those challenges. The sad truth is, though, that none of this is new, but it just constantly gets marginalised.
That's great points. I'll bring in James, yeah.
Just to build on what Caroline said, there's no way the sort of hospital system of the NHS can solve the problem in the way that you describe it. The hospital system of the NHS is not going to improve the fundamental health of the nation, nor should it. It is an amazingly good sickness service. If I'm ill today, I'm driving around to my local hospital and get really good service there. The whole of government needs to lend itself. So your question was specifically, where do we find the capacity when the secondary care system is running red hot, when bed capacity is maxed out, where workforce is super stretched? The question, the NHS can't do it. There's no way. You have to find capacity elsewhere. And that's why the rest of government does need to come into play. I mean, we've really struggled to get the housing system to put healthy homes as a housing priority. We have done very well, I think, on air. The air is being cleaned up, and we're making great progress on that. The Khan review, I mean, Caroline mentioned it, stuck in, God knows where it's stuck, but that needs to be liberated. There's a lot that the education department can do, the transport department, these other areas must be brought into bear. Otherwise, we can't tackle it. The drivers of ill health are not simply the success or failure of the doctors you go and see. They are the environments you live in and the personal decisions you make. And unless there's a realization that other parts of government have a bearing on that, then you're right, we can't solve this.
One of the things that I was going to draw on, which has come up quite a lot in the questions already, and it's related to some of the problems that we've talked about, but is a question about leadership, which is perhaps part of the problem that a lot of the people that we expect to do system leadership, both at a national level and at a kind of ICS level now, are people who have a background which is in the kind of acute trust sector. Is it a problem of being actually able to understand from leadership perspectives how health is created or how to work with other services that are health creating? Is there a kind of mental block that's going on there? I might pass to Norman to start off with that one.
Quite soon after I joined the Maudsley, we were developing our new strategy, and I said to one of the senior people in the trust, we need to focus on prevention. There's been very little debate about how we prevent mental ill health in our country. A welcome debate about mental health, and it's come out into the open, but we don't think about how we prevent it in the first place or prevent its deterioration. And the answer I got was, we're not commissioned to do that. And I just thought, oh my God, this is what I've come into. And I mean, thankfully, that didn't prevent us from making the shift in the strategy and setting out a sort of route map to achieve change, because I was persistent with it. But that is too often the mindset, and it's very narrow thinking. It's passive. You know, people within the health system wait for demand to hit them and then try to deal with it, usually with very long waiting lists, without really engaging. Now, there is an opportunity through the ICS system. The jury's out as to whether it will get anywhere. And my worry is that it just ends up bogging everyone down in vast numbers of meetings without the radical thinking that is really needed to move the dial on this. And also the need to recognise, as I said earlier, and Caroline's commented on, that so many of those determinants of our health lie outside the health system. And unless ICSs really engage in that debate and find mechanisms to drive change, nothing will happen.
Can I bring in James on this one?
Thank you. I mean, listen, 100% yes. And I say this with love in my heart for our senior clinicians and trust CEOs who do it fabulous. But at the beginning of the pandemic, I had personal first-hand experience of our public health capabilities in this country. And they were no good at all. They just weren't there for us. We had overlooked them for far too long, and they spoke of a country that just hadn't prioritized public health in the way that a country like South Korea or Taiwan or Japan does, or even Spain or Italy. And that's been a big mistake, and we're reaping the harvest from that, frankly. But also in social care, you know, most people in social care are under 60. Social care is not just elderly people. It's people who we're trying to find support for, and if we fail, they end up in hospital. And when social care fails, the queues in the hospitals get bigger. And UXA, you know, we should have been learning from the pandemic that we need a massive investment in our public health capability, in our screening, in our diagnostics, in working with schools and communities. UXA's budgets have been ground down, their staff demoralized, many have left. It's a real abject failure to apply the lessons of the pandemic. And OHID should have been a big exercise in trying to make Britain healthier. It's very denuded. It's a data provision service to local authorities. And the grant to local authorities, I read in the papers, has been cut by 25%. We haven't had the final announcement on that. I hope it's not true. But why on earth are we reducing the role of local authorities and the resources that they need in order to promote public health? This stuff is not wise, and it's building up again and again the queues and the demands for secondary health. And it's the most that a CEO of a secondary care trust can do, is just to keep up with the long line of ambulances outside their front door.
Caroline, did you want to come in on this one as well?
Well, I agree with everything that has already been said. I would just say the thing is as well is that, of course, you know, the NHS holds the purse strings when it comes to what you can deliver in communities, and that is about the hospitals, but it's also in terms of GPs and the model for primary care, which you know has to be more than seeing a doctor. We have allied health professionals who are excellent in what they do. We have nurses who, thank God, have been enabled to do undertake treatments and procedures that, you know, the demarcation lines were completely ridiculous in the past, and we're probably not using that to best effect. But importantly in all of this is when it comes to the discussion at the table, you know, our local authorities aren't there, if you like, as first amongst equals. You know, and so we end up with a sort of, you know, a tit for tat almost situation where we know to get these people out of hospitals into supported care in the communities. And James, I'm so glad James has said that most of the people in need of social care are under 60, because that often gets lost in the debate as well, is they haven't got the resources, they haven't got the facilities to do that. And I think, again, that just works against some unity amongst a lot of different diverse partners to find some solutions in this. And just for today, when I was Public Health Minister, I did try to establish a cross-government ministerial board with a representative from each government department, pretty much, on public health, because my opinion is there should be a public health minister in every single department, pretty much, that exists, to try and engage on this broader level of what we need to do.
Fantastic. I know that one of the questions that coming up a lot in the Q&A is about kind of taking the politics out of this. So there's been some suggestions both in the Q&A and I know in the media in recent days about, or for the last few years, about having a kind of non-party or a kind of non-aligned commission on the future of health. Is that something that the panelists think might make a difference in terms of sorting out some of these problems, or is that kind of another distraction when we know what we need to do and we just need to build the political will to get there? I'll pass to Caroline first and then to James.
We do need it, but we shouldn't underestimate the difficulties getting there, because politics is politics, and it all, you know, when things are working well, you don't really hear politicians of any party saying that's working well. They just keep quiet and keep under the radar on it. When things go badly, oh my God, everybody's all over it. And some of that is, you know, right for accountability and scrutiny. Some of it is more about opportunities. We do need a different level of debate on this, and maybe that comes to how do we create that wider debate in public so they demand more from politicians in what they do. And you know, I work with Norman, as he said earlier, others have tried in different fields as well, but we do need something, because if you look at social care, and I was thinking about this, you know, Andy Burnham, you know, did raise some issues around funding for social care and ended up being accused by Conservatives of actually something very similar that they would then accuse Theresa May of in terms of death tax and what have you. And therefore, you know, it is just imperative that we can move beyond this sort of sterile level of debate, because, you know, we might not be around, all these politicians, in 50 years' time. The NHS might not be around, and other services won't be around to do the job they need to do. And we should be more ambitious. And coming together in politics is sometimes the best way forward to achieve some change over these massively important issues, but also that affect generations for decades and decades to come. Look at there's problems with our pension scheme, but we have a state pension scheme. There's problems with our welfare state and how it works, but at least we have the welfare state. And a lot of that came about through sign up across parties to value it, still have different views, but undervalue the need for something like that for a good society. And this is another example of where we need that collaboration to happen, and soon.
So I get James's thoughts on this.
Yeah, no, I agree with Caroline. You can't take politics out of it. I don't think that a royal commission is going to somehow solve the problem. But what I am really conscious of is on my right, there are libertarians who do not believe in socialized medicine, who do not believe that we should infantilize the country by making decisions for them on what they eat for breakfast or what air they smoke or what they decide to smoke in the pub, and who would like to leave everything up to the individual. I just don't think we can afford that model in the country. It's economically unsustainable, and we've tested it. It's just too expensive. On the other side, there's a group of people who think that talking about health structures is irrelevant unless we do a fundamental redistribution of the wealth of the country that solves the underlying poverty issues that affect 25% of the country and has them living in unsustainable housing with poor education and poor diet. And unless you commit to a wholesale redistribution of wealth, then everything else is beside the point. I don't think that's sustainable either. It's politically not on the cards. I don't support that. I believe in the market economy and liberal society. And so that's off the table. In between, there is some space. And the politics of it is more about the centre versus the local. It's more about Andy Burnham making the case for a Manchester health budget or a West Midlands health budget than it is actually between the parties. And I do agree with Caroline, it would be great to reduce some of the toxicity about sensible measures, for instance, on how we can pay for social care. But I think that there is a space there for thinking about really, basically believing that health policy can work and having some courage and some optimism about investing in this area. That's what it's missing, as I said in the beginning.
As a quick aside, Caroline mentioned the death tax issue. I remember in 2009, as the Lib Dem spokesperson, I brought together Andrew Lansley and Andy Burnham. We had discussions, the three of us, in a room together. We drew up a statement of principles between the three of us about reform needed in social care. And then the whole thing was blown out of the water by the Conservative attack on Labour for the so-called death tax. And it made the whole initiative impossible to deliver. And so all parties have a responsibility. It's not, that particular criticism of the Conservatives is not exclusive to the Conservatives to behave in that way. Political parties are capable of doing that. And I think in a way, our best chance is following the next election, if there is a government that has a good majority and an appetite for reform, to then open it up, to have the self-confidence in the aftermath of a big election win, to open up a process to engage and involve other political parties and the public to achieve that new settlement, because it requires something quite fundamental. Just further tinkering around the edges is simply going to deliver more of the same.
Fantastic. I know we've got a huge amount of questions streaming in about prevention and public health, which is fantastic, but I do want to bring in a question specifically on healthcare delivery. And I think it's a fantastic question, so I'm going to read it out in full, even though it's a little bit long. So the question is, do we get too distracted in the system by reorganizing and joining up bureaucracies when what we really need to focus on is the relationship between professionals and individuals, which is currently about individual transactional relationships rather than kind of building more long-term caring relationships with those who need ongoing and long-term support, who are the kind of majority of kind of cost in the system and also the majority of users. Is there something here about actually rethinking the delivery model as well? And what makes it hard to do that kind of change?
Well,
I might start with Hon.
I think you've got to facilitate that sort of behaviour in a way. And I'm thinking about the mental health world, where we've, as a system, we've managed to introduce change that results in constant changes in people's, the clinician responsible for someone's care. So people get shunted from pillar to post. There's no continuity of care, no relationship building. And so we almost put obstacles in the way of people's recovery. And I'm sure that there are similar features in the physical health space. There's sort of the big gap between secondary and primary care, for example, is often very unhelpful. Just think about an older person with a range of chronic health conditions trying to navigate their way through a jungle, effectively, with all sorts of different providers. This isn't, we do not offer joined up care with any continuity of support for individuals. And I think it would be unrealistic just to expect people just to change their behavior within a system that doesn't really incentivize people to behave in that way. I think you've got to create the conditions where people are empowered to behave differently. And there is an enormous need for culture change within the NHS and the care system.
Can I pass over to Caroline?
I think it's right. We should look at closely at delivery, and I think, you know, part of this is also putting patients at the heart of that discussion as well. And those patients come in many varieties too, in terms of needs. So if you just look at something around, you know, IT and creating a sort of a digital NHS, I mean, interestingly, as a result of the pandemic, there was a massive uptick in GPs wanting to use this. As an MP for 22 years, living in Doncaster, coming down to London on a Monday, going home on a Thursday, oh my God, I would have loved to be able to avail myself of an appointment online. And so that's a good positive. But I would say within the system, there probably still isn't enough appreciate of taking the patients with you on this. And I'll give you another example. I recently went for a screening, got a call for a screening, fantastic, got that, came into my phone, went for my screening, did all that. 3 weeks later, I get a text saying you haven't attended your screening, you know. So again, for people to have confidence in these systems, and that resulted in me then having to get onto my GP surgery, try to speak to someone, trying to make sure it's done. We've got to make the systems that we use, they've got to be common sense to the people using them. We should recognise that not everybody has got the same confidence about using these systems. But fundamentally, whatever we're trying to deliver, think about the person at the heart of this and their journey, and who are best placed to be the anchor person for that journey, even if there are other people who are going to be part of package of support and care for that person.
Absolutely.
Because I think that's really missing too often on the social care side. There are still assessments being done by clinicians, and then they also have to have another assessment done by someone from social services. Now, I know there are reasons for that, but some of it seems to be cultural rather than actually focused on performance and outcome.
Personal health and care budgets are a welcome reform, giving power to people.
Can I bring in James on this one?
I mean, Caroline just nailed it, so I'm not going to add anything to what she said. Can I just pay testimony, though, to, since Caroline mentioned telemedicine as being the case study of how the pandemic made 10 years progress in 10 months. I mean, it really was a phenomenal turnaround. We have Dr. Simon Eccles on the line. He was the Chief Clinical Information Officer at NHS England, who drove a lot of that progress, and it was a real achievement. People had pushed hard on that agenda for a long time, and then when the rollout happened, they were ready. And getting treatment and diagnostics into the community and into people's home, I think for me is like the really big, rich gain that we could be making.
That's a great point. I'm going to come back now. I'm going to move away. The reason I've raised the issue about healthcare delivery is there's questions in the chat, and I remember someone recently telling me that the only thing harder than herding cats is herding doctors. So I think there is something to explore here about how you get kind of clinicians brought into the process of reform. But I do want to come back to some of the questions that people are asking about the kind of central and local divide here. One of the questions that we've had in the chat is really about how you strengthen that working relationship between the NHS and local government. Is the ICS the right model for doing that, or are there other ways in which we could facilitate better working between the NHS and local government? And I might pass to Norman first on this one.
Well, I think the ICS model is flawed, and I think Caroline touched on this. Local government is not an equal partner in the ICS model. They have a place on the ICS board and in the partnership structure. It's all quite complex, but they are not equal partners, and it's fundamentally an NHS structure, and I think that needs to change. There are opportunities for ICSs to sort of take advantage of the flexibilities to develop the model further, and I would certainly encourage them to do that. But you know, I would want to move towards essentially pooling budgets at locality level so that you align the incentives of the health and the care system. At the moment, you get awful perverse battles between health and social care over who's financially responsible, which is completely destructive of any rational distribution of resources. And so, when we introduced the Better Care Fund, my ambition, this was bringing together health and care funding with a requirement for localities to think differently about how that shared resource was used. My ambition was for that to develop into the mainstream way of resourcing the health and care system, so that everyone saw there was a budget for Manchester or for Norfolk or wherever it might be, and then you could start using it in a more rational way to focus better on how we prevent deterioration of health and keeping people well. But until we move in that direction, I don't think much will change.
I might pass on to James.
Well, listen, Norman's clearly written a book on this, so I support what he says. A lot of it is about the quantum. It just depends on how much money there is. And I remember a phone call in sort of March of 2020 when I said I had about 10 council leaders on. I said, right, what I really need you to do is to find a car park, get some cones, get some trestle tables and a gazebo, and we're going to send you some tests and we're going to start testing people. Any questions? And there's like, one lady put her arm and said, where do we get the trestle table from? And she was serious. She wasn't being unhelpful. It was like, I just suddenly realized, oh my God, there's just no money at all. I was like, well, I can give you my credit card number. I mean, it's sort of like, and it's just it's quite tough. I mean, I sympathize with local authorities. They see DHSC as being a sort of funding stream, and it's just a rather sort of half loveless relationship, and that's why the policy is hollowed out and, as Norman said, slightly nihilistic and difficult. So I think this one is definitely a funding issue, and it breaks my heart that some of that funding is being reduced even now.
Fantastic. And Caroline?
The only thing I would add to this is whether, and one of the things about assessing the successful progress that ICSs can make is whether or not they using their strategy, and the strategy is determined by other partners apart from health, is whether they really use that to identify ways in which the traditional health providers, for example, tackle health inequalities and tackle prevention as well as treatment, and in doing so, the opportunities to release some fundings to be shared more equitably across a range of partners, including local government, to play their part in this as well. That's something they could be looking at. That's something they could be addressing. But I think too as well is, I mean, money is always going to be the issue, but I think also it's also worth looking across the piece at public spending in other areas, transport, we've talked about education, environmental health, and say, well, look, of all the things we're doing, how does that contribute to better health? How does that contribute to public health? And how do we make some of those connections? Because I think still they're happening in some places, but they could be a hell of a lot better in terms of creating that environment where we're passionate about our health, all of us.
Final question from the chat before we go to closing remarks. And I know we could talk about all of this all day, but one of the questions in the chat is about the role of businesses. And I wonder if part of the problem here is that we spend a lot of time focusing on the future role of public services in delivering better health outcomes, but we neglect what's out there in our communities and our business and employers. Is there something about bringing along the private sector and the third sector along on this journey that's been missing, or the missing ingredient from past reform efforts? I might go to James first on this.
Yeah, Sebastian, I think that there is, in all the sort of gloom that I said about ambition and confidence, the business sector does seem to be stepping up. I pay tribute to John Godfrey, former number 10 advisor who is at Legal & General, and he's running hard at the Business for Health organisation with Tina Woods and Jordan Cummings at the CBI. I mean, there's a good gang now trying to really put this on the agenda. It was slightly dispiriting during the pandemic that business on the whole was not keen on owning the health of their employees. They didn't want to bring in diagnostics on the whole into their business or be part of that solution. That was quite different in America, where there is more of a tradition and a structure around business involvement in health. But out of the back of it, I think the lesson has been learned that there are massive workforce issues. You've got to hold on to your workforce and stop them from getting ill. And you invest so much in them. If they don't make it to work because they're ill or they quit early, it's going to cost you a fortune. So I think that there is a real momentum about this, and business can make a big difference, particularly in mental health. And that ranges from acute mental health issues to just the more softer well-being type issues. This fall off of the 50+ inactive group, we don't understand it. I don't understand it. We're going to have a big prod at it. We're going to look at pensions. We're going to look at waiting lists. We're going to look at long COVID. But the workplace and the pressures that people feel under in the workplace, it's got to be somewhere in the mix. And I do think that employers need to look really, really carefully at what they can do to promote healthy living amongst their workforce.
Fantastic. I might pass on to Norman with a mental health hat on as well.
Yeah, I don't think we can get engagement simply by encouraging on a sort of voluntary basis business to do more. The good businesses will do it. They recognise, as James said, that they have a direct interest in a healthy workforce, but there are so many businesses that don't see it as fundamental to their role. Simon Stevens, when he published the 5-year forward view for the NHS, talked about whether we needed to look at fiscal incentives to encourage businesses to play a greater part. And when I chaired a mental health commission in the West Midlands back in 2017, we actually came up with the idea of trialling what we call the wellbeing premium, a fiscal incentive to businesses to engage in evidence-based approaches to maintaining the health of their workforce. And I think you could develop those ideas, but you need to incentivize businesses to at least upfront to sort of act as a trigger to get them to recognize that actually it's in their own enlightened self-interest to maintain the health of their workforce.
And Caroline.
Well, I think the thing is that we've got to remember that most people aren't necessarily working for a big corporate firm. And in fact, some of those people who work for corporate firms are actually subcontracted. So actually how much a big, top 200 company is responsible for the employment of its cleaning staff or security staff is a moot point. And we found this when it came to wages. A lot of these companies said we pay the living wage, but they weren't necessarily paying it to those workers. And those workers working in manual jobs, probably in poorer housing, and what we've already discussed on this call today, are the ones most at risk as being in poor health. So I think there's a real issue here about, if you're talking about businesses, we just can't keep going to the ones that are, the big players who are probably doing it already, as Norman said. We need to have a different offer. Probably, I'm going to say, probably in somewhere like Doncaster, most people actually work in the public services in one form or another, which again, I think is another interesting. But on a wider point about involving ideas, I think certainly what's interesting is I think the private sector, parts of the private sector and business sector could help health with understanding more about managing their systems and data and IT. I think that's an area. And on the discussion around sort of smaller organisations, I would have to say again, as Public Health Minister, when we were trying to look at sexual health, the people who were most engaged with us on that were from the voluntary sector and the charity sector. And without organisations like the Terence Higgins Trust, who are much more agile and able to innovate in a way than maybe some of our sexual health clinics were able to do, we wouldn't have made some of the progress we did. So again, I think there are parts of communities that have gotten into this that can enable us to do things differently. What government has to stop doing, though, is constantly having pilots that are really successful, and for whatever reason, they never flourish. We are rubbish at sharing good practice across public policy in this country. And until that gets better, alongside some of the other things Norman and James have talked about today, we're missing a real opportunity There is good practice out there. I'm a what works person, and I can never understand why we don't cultivate that and enable it to thrive in other settings. And so much money has been wasted in not doing that.
Fantastic. We are out of time. I've realized we've hit 1 o'clock. So I wanted to say a huge thank you to all of our panelists today. I know there's a huge amount that we could, as I said, dwell on all day, but thank you to Norman, James, and Caroline for what I think has been a fantastic session. Quick little plug at the end. At Reform, we are doing a big program of work on reimagining health, and a big focus of that is what we've talked about today. So the future of prevention and public health, how we do more at a local level and a national level, and how we have a serious conversation about health creation rather than focusing on healthcare. So if you do have thoughts, do reach out to us. But I'm gonna bring the session to an end today and say thank you very much to our panelists and to all of you for such fantastic questions. Thank you.
Thanks very much.